Hi, everyone. I'm Ann Korkidakis. I'm a third-year reproductive and endocrinology and infertility fellow at Boston IVF. The program is affiliated with Beth Israel Deaconess Medical Center, as well as Harvard Medical School. I'm actually graduating in June and will be joining on the Boston IVF team as an attending, which I'm thrilled about, and hopeful to meet some of you in the upcoming months. I also wanted to say a happy National Infertility Awareness Week. I think it's incredibly important to acknowledge that 1 in 8 couples do experience infertility in their lifetime. I think acknowledging it increases research resources. I think that it improves access to care for our patients. And it also helps reduce some of the stigma associated with infertility, because despite 1 in 8 people experiencing it, I know it can feel incredibly isolating when you're going through it yourself. So incredibly important. And I'm happy to be hosting a Facebook Live during the week. The last thing I just wanted to mention is I'm just getting over a cold and I think I'm quiet at baseline. So I apologize if my voice is a bit raspy or hard to understand. Feel free just to let me know and I'm happy to repeat or clarify anything that might not be clear. All right, so we have some questions coming in. One of the first ones I see here is, can I do PGTA on a frozen embryo? So just to provide some clarification, PGT is preimplantation genetic testing, and they're probably referring to PGTA, so preimplantation genetic testing for aneuploidy. And what that does is it is a lab technique that takes a few cells of an embryo when it's at the blastocyst stage. That's usually around day 5, day 6, or day 7, when the blastocyst or embryo is composed of hundreds of cells, some organized into the inner cell mass that will become the embryo, and some organized into the trophectoderm that will become the placenta. So the lab's able to take approximately 5 to 7 cells of the trophectoderm, which will make the placenta, and send it for genetic analysis. And what it looks at is to see if this embryo is likely to carry the correct amount of chromosomes. So what we're looking for is 46 chromosomes, so 2 sets of 23, one from each biological parent. And this test is a screening test to see if the embryo does carry the right amount of chromosomes, which is important because if you have a chromosomally normal embryo or euploid embryo, it has a very high chance of implanting and leading to a healthy baby. So the question, usually this is done during a fresh IVF cycle where we retrieve eggs, fertilize them with sperm, grow them to the blastocyst stage, and take cells out at that time. The question refers to whether or not this can be done on an embryo that's been already frozen. So what that would consist of is thawing the embryo and then the lab proceeding to take a few cells of the trophectoderm. And the easy answer is yes, it definitely can be performed. We can thaw them and then biopsy the embryos. It's not ideal because it seems like it does reduce the implantation potential of the embryo a little bit. So usually a euploid embryo has about a 55–60% chance of implanting. And we know that doing this thaw and biopsy reduces that rate by maybe 10 or 15%. So still very high, but we always are very cautious and thoughtful when considering thawing embryos to do biopsy. So if you've had multiple failed implantations or some miscarriages, then it definitely can make sense in your case. And I encourage you to speak about it a little bit more with your team. So it's definitely something we do, but we are very thoughtful when deciding to thaw embryos and biopsy them. The next question is, thank you so much for doing this event. You're welcome. What's the efficacy of 7-day PGTA normal embryos? That's a great question. So I just spoke to the fact that when we have a euploid or chromosomally normal embryo based on our PGTA results, its chance of implantation, if it's a day 6 or day 5 embryo, is about 55 to 60%. Now, if it's a day 7 embryo, that means that it took an extra day for it to form a high-level blastocyst. So that embryo with hundreds of cells that's well organized into the trophectoderm and inner cell mass. and has high enough quality of cells that we think it's worth biopsying. So the embryo took an extra day to get to that point. So it wasn't ready on day 5 or day 6, but was ready on day 7. It's interesting because when we biopsy them and they're euploid, we still have a high potential, but it's definitely less than day 5 or day 6. It's closer to about 30 to 40% chance of implanting if you have a day 7 euploid embryo. And that speaks to the fact that, knowing the chromosomal status is just a small part of, why an embryo can lead to a healthy baby or not. So it doesn't speak to the metabolics of the embryo. And there's other factors at the gene level that also can't be well studied at this stage. So there's a reason that it took an extra day to get there. It is associated with reduced implantation potential, but that being said, it's still quite high. And we have a lot of healthy babies born from day 7 euploid embryos. So definitely worth considering. Another important thing is that does factor into us deciding, or the lab deciding, which embryo to transfer first. So they tend to prioritize a day 5 or day 6 euploid embryo over a day 7 for that reason. Another question here about transfers. So FET is an acronym for frozen embryo transfers. What's the difference between a letrozole, HCG, and progesterone suppositories versus the estrogen patch and progesterone in oil shots? Is there a reason for choosing one or the other? Thank you. So there's really 2 kind of categories of frozen embryo transfers. One is a natural or modified natural, and that refers to what we call HCG protocols or letrozole protocols. And the other one is a medicated or programmed frozen embryo transfer. So the first one, a natural or modified natural, essentially what we do is we take advantage of your own menstrual cycle to get the lining ready for implantation. So what happens in a normal menstrual cycle is you have a cohort of eggs that start developing. They produce estrogen as they grow. Then one takes the lead, you end up ovulating one, and the rest die off. So that estrogen that the cohort of follicles is making gets the lining nice and thick. And then once you ovulate, whether it's on your own or if we trigger it with HCG, hence the name, then it forms a corpus luteum. So you release the egg and the cyst that's remaining is called a corpus luteum, and that makes progesterone. And that gets the lining ready for transfer. So that's what we time the transfer based, is when you start being exposed to that progesterone produced by the corpus luteum. So essentially, we're just taking advantage of what your body's able to do on its own, which is thicken the lining. And then once it's exposed to progesterone, decidualize it, getting it ready for an embryo transfer. The benefit of this cycle is the fact that because your body is producing its own hormones, we only need to give a small dose of progesterone to further just sustain the pregnancy. It's actually arguably might not even be needed. So that means you can take smaller doses, usually just vaginally through crinone or endometrium. And that's enough because your body's making most of the hormone it needs to sustain the pregnancy. The other type of transfer protocol or frozen embryo transfer protocol, the medicated or programmed one, is when we take a complete overhaul of your menstrual cycle. So we start higher doses of estrogen to thicken the lining, and these high doses of estrogen in general prevent you from ovulating or developing follicles on your own. So we're doing a complete overhaul of your menstrual cycle. So you would take high dose estrogen, we would make sure that your lining's responding and getting to the right thickness. And then once it is, then we would have to give you exogenous progesterone because you don't have that corpus luteum cyst to make your own. And because you're not making any of your own hormones, we need to give you higher doses. And there's a study showing that if you take intramuscular progesterone in these protocols, then outcomes are better. Now you don't need to take the intramuscular every day. Every 3rd day is sufficient with vaginal progesterone in the middle. But essentially it does require taking an intramuscular injection. So that's the detriment of a programmed or medicated frozen embryo transfer cycle, is that usually it necessitates taking progesterone and oil, which are intramuscular injections and can be quite uncomfortable. In terms of outcomes, they're very, very similar. So we looked at our data very closely, and it does seem that the success of having, a healthy live born at the end of it is very similar with one protocol versus the other. Sometimes women who are, approaching menopause, if they're not cycling on their own, then we need to do a medicated or program cycle because we're not able to kind of take advantage of their own body producing these hormones. So that's why sometimes we pick one versus the other. And sometimes when one doesn't work, we try a different approach. So they're both very useful, but that's really just kind of comparing the two and how patients experience both of these cycles. The next question is there anything you can do to prevent continuous miscarriages? Oh gosh, that's so frustrating. So the term for that would be recurrent pregnancy loss, or RPL. And the definition of RPL has definitely changed over time. Traditionally, it's thought to encompass, you're thought to have that diagnosis if you had 3 miscarriages that were clinical. So we saw a heartbeat on ultrasound, or we saw a pregnancy in the uterus that didn't continue on. But over time, we've noticed that even patients experiencing biochemical losses, meaning their pregnancy hormone rises and then falls, so very early pregnancy losses, even those are very significant in terms of both prognosis, so having a healthy baby, but also in terms of if we do a workup, are we going to find something useful from that workup? So for those reasons, now we consider biochemical pregnancy losses to be in that definition, so very early pregnancy losses. And you actually only need 2, and they don't necessarily need to be consecutive for us to start considering at least an initial evaluation. And what that evaluation consists of is really kind of 4 broad categories. One is genetics. So we're all born with, in general, 46 chromosomes. Sometimes we carry a rearrangement that makes it more difficult to form normal embryos and leads to pregnancy loss. So we can look at the chromosomal status of both partners in a relationship to make sure that that's normal. The other testing that we would do is endocrine. So making sure your thyroid function is normal, because that can affect fertility as well as pregnancy loss. Making sure that your prolactin's normal. That's a hormone secreted by your pituitary and can cause, again, issues with fertility and pregnancy loss. Making sure there's no pre-diabetes or diabetes, because that's very impactful on pregnancy loss. So the second category would be endocrine. The third would be if you carry a predisposition for forming clots, something called antiphospholipid antibody syndrome. So we do testing to see if you do carry that predisposition, because if you do, then there's really good data that treating you with aspirin and then a blood thinner called heparin is very helpful in preventing further pregnancy loss. The fourth category is anatomic issues. So sometimes you might have some scar tissue from a prior pregnancy loss. You might have a septum, which you're born with, which is essentially a heart-shaped uterus where the peak kind of descends in. And those things, if the pregnancy does implant on either the septum or scar tissue, those aren't very well vascularized. There's not a great blood supply to these structures. So that also predisposes to a pregnancy loss. So I think the first step is taking a really good history, doing a physical, but then also evaluating for these 4 categories of abnormalities. If we find something, then that's very incredibly helpful, because oftentimes we can target treatment to that. So if you have a chromosomal rearrangement, we could test embryos to make sure they don't carry it. If you have an endocrine issue like diabetes, we can treat that prior to conceiving. If you have an anatomic issue, we can treat the scar tissue or the septum prior to trying again. Unfortunately, even if we do a very, very thorough evaluation, in approximately half of couples, we won't find a reason. So it'll be called unexplained recurrent pregnancy loss. And that's really, really frustrating because we go through all this testing and we still can't pinpoint a reason. But the truth of the matter is that most times miscarriages are random events. They're unfortunate, but they're random events. It's just that, your chromosomes in the egg didn't come completely together properly with the chromosomes in the sperm to form a chromosomally normal embryo. So usually they're random events in this unexplained pregnancy loss group. So the prognosis is really good. You have a really, really high chance of having a healthy baby moving forward. But I still think it's very important after 2 or more losses to consider evaluation, make sure we're not missing anything, and then discuss the options. And another option that we've been exploring for recurrent pregnancy loss is doing pre-implantation genetic testing for aneuploidy or PGTA that requires an IVF cycle to create embryos, but then we can actually test the embryos to see if they're normal. And if we do have a chromosomally normal embryo, not only does it have a high chance of implanting, which we spoke about, but it also has quite a reduced risk of miscarriage. So the baseline risk of miscarriage could be as high as 15 to 20%. If we transfer a normal chromosomally euploid embryo, the chance of miscarriage is less than 5 to 10%. So it's unclear if it's necessarily required in this situation, but in individuals or couples that want to do whatever they can to reduce the chance of a further loss, it's definitely an option worth speaking about. I think this kind of builds on the last question. Is it factual to say that it's more likely IVF will work if I had a miscarriage in the past? People will say, well, you got pregnant once, so you can implant. Is it true? Is my lining okay, but maybe my egg quality isn't great? All the wonderful advice we get from family and friends, well-intentioned, but it can also not necessarily be the right thing to say at the time. But there definitely is some truth to that. So there are studies that show that if you've had a pregnancy, even if it resulted in either a pregnancy loss or an ectopic pregnancy, then you're in kind of the highest prognostic group for having a successful live birth, either on your own or through assisted reproductive technology, so IUI or IVF. And that's because all the events worked up to a point. So that means that, you ovulated an egg at the right moment, produced the right hormones, the egg was released, the sperm was able to meet and fertilize the egg, the embryo was able to start dividing, making those divisions and needs, and then implanted in the uterus and started growing after being connected to the maternal blood supply. So there's so many checkpoints that you got past that we know works in you. So it's actually a bit of a silver lining when you've had a pregnancy loss, because it reassures us that a lot of the biology is functioning. As I discussed, the most common cause for loss is chromosomal abnormalities in the embryo. Again, not that your chromosomes are abnormal, or your partner's chromosomes are abnormal, just didn't come together perfectly. And that does increase with advancing female reproductive age. So we do see miscarriage rates go higher in your mid to late 30s. But it can happen to anyone, even in young women in their 20s. So these chromosomal abnormalities are the most common cause or responsible for the vast majority of miscarriages. And having 1 or 2 miscarriages really doesn't impact your chance of having a healthy baby down the road. It definitely doesn't make it lower, and in fact might make it a little bit higher. So I would say that you have no reason based on 1 or 2 losses not to be very hopeful. It might speak to egg quality. That was a second part of the question, in terms of as we age, there's more of a chance of our eggs being abnormal. The reason for that is because we are born with all the eggs we'll ever have. And they're kind of arrested in the stage of meiosis, which is cell division. So most cells in our body have 46 chromosomes, but an egg needs to get to 23 chromosomes to be able to meet with a sperm that has 23 chromosomes and form a cell of 46 chromosomes in total that becomes an embryo. So your eggs are kind of stuck at this point of meiosis, where all the chromosomes, the 46 chromosomes, are lined in the middle, and they're attached to the poles by something called meiotic spindles. And these meiotic spindles are made of protein. And over time, just like all proteins in our body, they do start to degrade. So the longer they wait to divide, the more chance there can be these little breaks in the spindle. And what the spindles do is they separate the chromosomes into two cells. So if you have breaks, you're more likely to have an imbalance in the chromosomal separation. So that means like an extra chromosome. An example of that is having an extra chromosome 21, trisomy 21, or Down syndrome, which we know increases with age. So again, this can happen. Chromosomal imbalances in eggs can happen really at any age, but the chance does go up with advancing female reproductive age. So it is definitely, that's why we do see the risk of miscarriages go up with advancing age, unfortunately. Again, though, having one or two miscarriages is not a negative prognostic sign. It doesn't really truly impact your chance of having a healthy baby. So it might speak a little bit to egg quality, but I think that overall, unfortunately, miscarriages are common, and you definitely can move on from them. What are some tips on telling people to stop asking when you're having a baby? Oh gosh. I don't know if I found a great solution for that. It's definitely something that I've personally experienced. And I don't think there's really ever an okay time to ask a friend or family member or even a neighbor or someone you barely know. One, if they're pregnant, because there's no good way to make that assumption. But two, when they're starting to have to try to have a family and when they're going to have that baby. I know that it comes from usually a place of good intention, but it completely diminishes all the struggles that could be going on behind closed doors, and just adds to kind of the pain of this whole process for everyone. I think it kind of depends on how close you are to this person and how comfortable you are. But, I think if you feel comfortable enough sharing your struggles and saying, actually, we've been trying for a very long time and it's been a huge stressor, I think it's very inappropriate for you to ask that. I think that's a quick way to kind of shut them down. If we're not feeling comfortable enough to do that, then I think just changing the subject and maybe asking them at a time where it's more of a private setting for them not to bring that up again. I don't think that anyone needs to explain themselves or share what they're going through if they're not comfortable. But I do think speaking about it does help break down the stigma. Again, there's no pressure because I completely understand how difficult of a journey it can be. But again, never appropriate to ask a woman if she's pregnant, even if she looks like she's about to give birth, and also never appropriate to ask when a person or a couple is going to have a baby. I think I'm preaching to the choir here, but yes. What's the ideal FSH prior to an egg retrieval? I'm 41, and during my last cycle day 5 draw, my level was 16.4, and the center I was working with said I wouldn't do the Clomid challenge. Is this usually a requirement for an IVF cycle? Are there any protocols that would lower my FSH level? So essentially what FSH is a signal from the pituitary to the ovaries. It's called follicle stimulating hormone, and it does exactly what that name says, meaning it is the hormone responsible for pushing forward that cohort of follicles and getting them to develop and grow. And just to be very clear, a follicle is a sac of fluid with an egg in it. So as these follicles grow, the eggs inside them grow. And as your ovaries decrease in the egg number that they contain, your pituitary has to work a little bit harder to push forward a cohort. So as your egg number goes down, your FSH actually goes higher because it's really trying to drive through the follicles and push them forward in the setting of a lower egg number there. So it's part of the egg reserve testing that we do. Usually we expect a baseline level, which is usually day 3 or day 4, to be less than 10 or 12. And unfortunately, some insurances do require a Clomid challenge test to be passed before they'll fund an IVF cycle. Now, I think that having a high FSH does indicate that you have a lower egg yield. And then you might not respond as well to medication. We might not get as many eggs as I guess the average person in a IVF cycle. But there's definitely data to show that just because you have a low egg number, it doesn't mean that it's impossible to have a healthy baby from an IVF cycle, even in the face of a diminishing ovarian reserve. So I don't think the Clomid challenge test is an ideal test because it definitely does not kind of establish those that will absolutely never benefit from IVF. There's no cutoff that tells us you don't have a chance from IVF, but it is a test that insurances use to decide who they'll fund with, I guess, their limited allocation of resources. So I think it sometimes ties our hands when you have an insurance company that requires a Clomid challenge test, because if you do not pass it, oftentimes they won't fund the cycle. Again, that doesn't necessarily mean that it's not worth trying the cycle, but obviously once it becomes self-pay, oftentimes it's cost prohibitive. Now, are there any protocols that would lower the FSH level? So there's definitely protocols that we use to help improve egg yield in an IVF cycle. So just to kind of go through what an IVF cycle looks like, I was alluding to the fact that every month women make a group of eggs, a cohort of eggs, you ovulate one and the rest die off. The rest die off not because they're abnormal necessarily. They die off because there's just enough FSH for really one egg or follicle to take the lead and ovulate. So what we do during an FSH cycle is we give you higher doses of FSH over about 8 to 12 days on average through injections right under the skin, subcutaneous injections, to try to rescue all those follicles that you're going to develop that month. Now, it doesn't take advantage of your eggs locked away in your ovary. It just takes advantage of that group of eggs that was released by the ovary that month, that cohort. So we're a little bit limited by the cohort size. So in women with a very good ovarian reserve, the ovary probably feels generous and will give 15 or 20 follicles that month to ovulate one. Whereas if you have a diminished ovarian reserve, it wants to hang on to those remaining follicles. So you might just make a handful every month to ovulate one. So really what we could do in IVF is just try to rescue that group. And we're a bit limited by the amount of follicles in that group. But we do have protocols to, one, try to really rescue every single follicle in that group, and two, to try to make them grow at a similar rate, because we trigger ovulation when follicles are roughly between 18 to 22 millimeters, because that usually signifies there's mature eggs in them. So we have different protocols. One of them is a microdose flare protocol, and that you take small doses of something called Lupron, which normally suppresses your ovaries, but in small doses, it actually makes you release your own gonadotropins, your own FSH and LH. And some women with diminished ovarian reserve actually benefit from that. And it sometimes is quite good at rescuing every last follicle that you're making that month. And that's why it's helpful. The other protocol that we often use for women with more of a diminished ovarian reserve is a luteal estrogen prime protocol. So you start taking estrogen either orally or through a patch right at your cycle, prior to the cycle you're going to start. So a few days after you would ovulate in the cycle, you would start this estrogen priming. And then you would get off and you would start the ovarian stimulation with those injections under the skin. And the thought is that women with a more diminished ovarian reserve have those higher FSH levels, like you said, you experience. And that leads to early follicular recruitment. So you might have some follicles that are developing really early and the others lag in behind. The goal with this luteal estrogen priming is to kind of suppress the ovaries. So there's really nothing that's starting to take the lead. They're all starting at the starting line. And I've seen quite a bit of success in terms of getting a really good tight group growing with this type of protocol. So definitely we see diminished ovarian reserve every day. And we certainly have, in our experience, different protocols that tend to work quite well for this group. Again, we do the best with what we have, and we do the best with whatever ovarian reserve that you have. Next question is, I had an IUI done last year, which worked, but this month it didn't. I had some progesterone symptoms, so I guess the embryo just didn't take. What could be some of the reasons the embryo didn't take? And is there anything I can do to increase the chances of my success? Well, I'm hoping that that means that the IUI last year worked and you have a baby from that. So if so, congratulations. I would say that, so the intrauterine insemination, what that means is essentially, usually we give you some medication prior to that. So usually we either give you Clomid or Letrozole, which is an oral medication that you take for 5 days. And the goal of it is to, instead of ovulating 1 egg that month, to try to maybe ovulate 2 or 3. So there's more targets. And then coordinate that ovulation to an intrauterine insemination, where a male partner, or you use donor sperm, provides a sample. The lab washes that sample, so you have a sample of really highly motile sperm. And then you put it in the uterus with a small pipette. It essentially feels like a pap smear. And that way the sperm has less of a distance. It's already through the cervix in the uterus, so it has less of a distance to travel to meet the egg, usually in the fallopian tube. And then the embryo would implant in the uterus. So that's the intrauterine insemination cycle. If you know anything about IVF, you know that it's, IUI is a lot less involved than IVF. You don't need the same level of injections. You don't need a small surgical procedure in terms of egg retrieval and then an embryo transfer. So it's a lot less involved. But the success rates are also a little bit lower. So if you've been trying for about a year without successfully conceiving, your chance of getting pregnant every month goes to less than 5% per month. So that functions as a baseline. Your chance on your own is about 5% per month if you've tried for a year and haven't been successful. IUI brings it back to about 10 to 15% per month. So it roughly doubles or triples it, but 10 to 15% per month isn't incredibly high. After 2 or 3 cycles, you get close to a 30, 35, 40% chance of success. And then after that, the success tends to plateau. So most people who do get pregnant through an IUI cycle get pregnant in the first 3 to 4 cycles. So what that means is after 3 or 4 IUI cycles, yeah, there'll be, maybe up to 40% that get pregnant, but there's actually almost a higher chance that you don't get pregnant from the cycle. And it doesn't necessarily mean that something's wrong. It just means that IUI, is has a low invasiveness, but also doesn't have an incredibly high success rate. It definitely works in some individuals, such as yourself. But we often sometimes overemphasize the success rates. And I think that it's easy to get discouraged when you do that. So I don't think there's anything wrong if the first one didn't work. If you got pregnant last time with it, and your testing since then has been normal, I definitely think that it's worth trying a couple more cycles. And you're probably someone who has a high likelihood of getting pregnant through intrauterine insemination. But that being said, after 3 or 4 cycles, it's always reasonable to consider alternative options. And sometimes that means moving on to IVF, and other times it means having that discussion and deciding to continue with IUI. So it's not always so clear cut. There's not a right or wrong answer. It's just what's right for you and your partner. So I don't think there's necessarily anything wrong in your situation. Again, I can't provide, very specific or individualized medical advice. I would make sure that, the cycle went well from your doctor's perspective. I would make sure that you've had tubal evaluation since your pregnancy, because over time, especially if you've had a C-section, sometimes that can cause scarring at the tubes and can make them blocked, and then you wouldn't be a great candidate for intrauterine insemination anymore. But all those things were done, and they look good, and it's just been one cycle that hasn't been successful, I definitely encourage you to try another 2 or 3, and speak more about it with your doctor. My partner and I are starting to consider reciprocal IVF. What should we be considering deciding whose egg to use and who should carry first? We're both open to carrying. I think it's so special that we're able to offer reciprocal IVF, and really get kind of every member in the partnership involved. And also from kind of a medical perspective, it gives you options in terms of, as you said, deciding who will be the one contributing the eggs. The first step really would be to speak to one of us, just so that we can get a bit of a medical history. Sometimes if someone has, experienced, let's say, gonadotoxic agents, I guess someone, this is an extreme example, but has had chemotherapy, that can impact ovarian reserve. Or if they've had any type of ovarian surgery, that could impact ovarian reserve. So kind of getting a clear, detailed history could be helpful. The other thing is age. As I discussed, age is incredibly impactful when it comes to ovarian, both reserve, so number of eggs, but also quality of eggs. So I would say in general, if you're your early mid-30s, generally we'd expect normal egg quality and normal egg reserve, but that's something that we could test, and that could provide some clarity on who would have the highest likelihood of contributing their eggs and it leading to a healthy baby. That being said, we appreciate that there's a genetic linkage. So sometimes the individual who might not be the ideal egg donor, or the one contributing the eggs, is the one who decides to go first because they want a genetically linked child. So I don't think it necessarily excludes someone, but having a discussion on what we can expect in terms of egg number and chance of live birth for both partners would be very helpful. So speaking about that further and kind of clarifying those points could give you a better answer. But good luck, that's exciting. The next question is, do I need to remove a blocked tube? Just my head anatomy here. So a uterus is kind of a triangular shape, and it's called the womb, where the baby develops. And then there's 2 fallopian tubes, and these function to capture the ovulated egg and transport it. The egg gets fertilized by sperm in the tube, and then the embryo implants in the uterus. For various reasons, you can have a blocked tube. And sometimes that you're born with it. Sometimes there's just scar tissue from a prior surgery. Sometimes there's scar tissue from something called endometriosis, which is very common. Sometimes if you had a prior infection, that can lead to inflammation and blockage of the tube. Now, if your tube's just blocked and it's not swollen, then it doesn't necessarily need to be removed. But if there is evidence of it being blocked and being swollen, something called a hydrosalpinx, that leads to a blocked tube where there's a lot of fluid accumulating, then that's really when it could be impactful and impact outcomes. And the reason for that is because you have this fluid that is building up over time, and it can be toxic to an embryo developing. So even if it's blocked at one end, it still can go back into the uterus and it can impact a developing embryo. And there's actually really good studies showing that if you have a hydrosalpinx, it reduces your chance of both having a baby on your own, but also through IVF, and it cuts it down by about 50%, which is pretty drastic. And this is something we didn't necessarily know a decade ago. So it's really interesting. But essentially, if you have a hydrosalpinx, then again, it's a little bit situation specific if you're a good surgical candidate, among other things. But my recommendation would be to speak to a reproductive endocrinologist and potentially a surgeon about, one, what does the other tube look like? Does it look functional? And if the other one does look like it's a hydrosalpinx, I think it's definitely reasonable to consider removing it before trying on your own or pursuing any treatment such as IUI or IVF. Just to clarify, once you remove the tube, it restores the pregnancy rates back to baseline. So I think overall, it's definitely reasonable to consider. Really hard to find time during the day. I agree. It's always a whirlwind during the day. I'm 35 with moderate PCOS. She's 42, also with PCOS and type 2 diabetes, a close partnership. Haha. With that being said, and age favoring me, is it a logical choice to use my eggs? Any issues with her considering PCOS and diabetes? So, hi, Stacy. Nice to meet you. I'm hesitant to provide any kind of individualized medical advice because I think there's so much to learn about a patient other than the helpful information you provided. I would say, it's important to speak to a reproductive endocrinologist because one is we would make sure, she's 42, so we definitely know the egg quality is impacted, but having an idea of egg quantity is helpful. I think given the difference in age and you having kind of a relatively young reproductive age, in all likelihood, whoever you speak to would favor using your eggs, but it definitely warrants further discussion. And then in terms of carrying, I think having a discussion about kind of general health and evaluation too, doing a test that, someone with very well controlled diabetes that's optimizing their lifestyle is definitely in a different state than someone with poorly controlled diabetes that hasn't necessarily been focusing on themselves. So there's a lot of things to consider, and speaking to a doctor could help clarify whether or not she can safely carry a pregnancy. So I think that that's probably the next step for you guys. I have done 2.5 IVF cycles, was told that eggs needed to be removed quickly due to stage 4 endo. My doctor told me I had 6 months to complete IVF, otherwise I would no longer have any options. I'm overweight and was told to do egg retrievals first and not put on hold to lose weight. After my miscarriage, the doctor told me to lose weight, and at that point, 6 months was up. Now is telling me to have a gastric bypass. Oh gosh, what a story. Again, I think this is a little bit complex of an issue. The question is about, prioritizing weight loss in someone with PCOS. Someone that's prioritizing weight loss in someone that's overweight, but also has endometriosis. So endometriosis is when the lining of the uterus is found elsewhere in the pelvis. Most commonly, it's found in the cul-de-sac, so behind the uterus, but it could also be found in the ovaries, leading to something called endometriomas, we call chocolate cysts, which are little packets, cystic areas of blood. And these little areas of lining in the pelvis respond to the cyclic hormonal changes just like your lining does. So when your lining sheds, these pockets of endometriosis also shed and can cause lots of pain, scarring, and then issues with fertility. So I could see that there's kind of a lot of factors here that's impacting both your health and quality of life, as well as your fertility. Again, without specifically knowing your story and your medical history, I think it's hard for me to give specific advice. I think more and more it's becoming clear that it's always a balance between for individuals who are overweight. There's data showing that it does compromise your chance of getting pregnant, both on your own and through IVF. But at the same time, it's been shown that, we all know age is very impactful. And we all know that it's not easy to lose weight. It takes time and dedication. And so is it worth taking a couple years to make that attempt to lose the weight, to undergo gastric bypass, but then be a couple years older? And we know how impactful that is in terms of egg quality and egg quantity. So I think that you really need to sit down with a reproductive endocrinologist if you haven't. And well, you clearly have because you've done IVF, but speak to the doctor you're working with about the pros and cons in each option. There might not be a clear-cut answer, but if you're in incredible pain, then potentially considering doing surgery sooner rather than later makes sense. If you're very young with a good ovarian reserve, then potentially, looking into weight loss or gastric bypass would make sense. So I think that there's not a really clear-cut answer, but speaking to your doctor, you can come up with a plan that kind of makes most sense to you. But you clearly have a lot of factors that you're managing and dealing with. So I hope that you have someone that can guide you through. Our first IUI was successful last September, but had a loss at 10 weeks due to trisomy 16. Oh, I'm so sorry to hear that, Shilpi. We did 5 more cycles after that without success. I do have hypothyroidism, Hashimoto's, and a low ferritin. Taking a break in May. Should I continue to do a couple more IUI cycles after the break? As our insurance can't cover fertility treatment and I cannot cover an IVF cycle yet. Oh, that's really tricky. I'm so sorry about the loss. I think the emotional, buildup after getting pregnant, then finding out about having an abnormal pregnancy is huge. So I'm sorry that that's something that you experienced. Again, I think the silver lining, and we spoke about this, is that we know that, you can get pregnant with IUI. We know that everything worked up to an extent and it just wasn't a chromosomally normal embryo. And that's why it didn't continue on. That being said, we also spoke about the fact that after 3 or 4 or 5 IUI cycles, the success kind of plateaus. It's not 0 though. So I think that it's definitely worth considering after 6 IUI cycles. One, looking over them, making sure that you're responding each month, the sperm is washing up well, everything looks good in the cycles and we're not missing anything. So I think at this time it's good to look back and be very clear that everything went as planned. And then to consider IVF, but that being said, if unfortunately it's not an option for you, it's definitely not unreasonable to keep on trying with IUI, especially in the context that it's worked for you previously. As you all probably know, I'm currently in Massachusetts, which is a mandated state, meaning that individuals with private insurance, most individuals with private insurance do have coverage for fertility treatment. And a lot of times you get that through employers, but there's also something called the Mass Health Connector, where you can enroll yourself into private insurance and for several months, and that could help with the cost of IVF treatment. So I don't know if you're in a state with a mandate, but definitely speak to your team more about the options for getting coverage, because if you are in a mandated state, there's a possibility that it might be more accessible than you think. Yeah. Next questions. I did the egg retrieval. Right now I have 3 frozen embryos. This month my period is late for a week and is still not coming. Is this normal? So definitely having IVF could throw off your cycles a little bit. So it's not uncommon after an egg retrieval to get your period a little early or a little bit late. So I wouldn't be too concerned. We always recommend for someone, having a delayed period to obviously do a pregnancy test, make sure we're not dealing with that. It's definitely not uncommon to have couples conceive on their own after treatment. So it's something we see a lot. So if that was the case, it'd be wonderful. But I would say that if you don't get in the next couple of weeks, speak to your team, because definitely, planning to move forward with a frozen embryo transfer, having 3 frozen is great, is based on your period. So speak to your team if it doesn't come in the next couple of weeks, and that if your pregnancy test is negative. Stacy, this is a follow-up for the couple considering a PAR cycle. And I don't think I clarified that. That's when there is 2 females in a relationship that would like to both contribute to starting a family. And generally one would do the ovarian stimulation egg retrieval cycle. We would create embryos using their eggs and donor sperm, and then the other member would have the embryo transfer and carry the pregnancy. It's so wonderful that we're able to do that. And I think Stacey speaks of the fact that most insurances do not cover this. And this is something that we are constantly advocating for. I think that the definition of infertility has definitely evolved over time from, it being a man and a woman and a year trying to conceive. And I think we're all recognizing that all types of individuals and couples need our assistance to start the family that they deserve. So I'm so sorry that you're in the situation where most insurance companies do not, but we're definitely very active in trying to kind of push that forward. Now, PAR cycles are a little tricky, but for same-sex female couples, some insurances, while they don't cover initial attempts at donor insemination, if you've had 6 unsuccessful attempts, then sometimes they'll start funding moving on with different types of treatment, like IVF. So sometimes insurance companies do come into play and do offer some support. But I completely agree that it is unfair, and it is something that we're striving to kind of push forward, because everyone deserves to have the family that they want. And I'm so sorry you're in this situation. But again, I think speaking to someone about what the options and actual costs are, and if there's any way that your insurance would contribute in one form or another, although I do agree it's always been tricky when trying to get PAR cycles covered. And I completely feel that, and I've experienced this with my patients, and I'm with you, Stacey. Do you also suggest any testing like Emma and Alice, and any supplements? What they're speaking to, Emma and Alice, are tests to look at the uterine environment. So to look at the microbiome. So the uterus is not sterile. It has its own both bacterial and yeast flora that help regulate it and keep it normal, maintain its pH, and help implantation. So there's more and more evolving where we're looking to see, is someone's microbiome sometimes related to their chance of getting pregnant through an IVF or IUI cycle. And, there's definitely some associations. So there's something called lactobacillus, and this is kind of the healthy organisms in the uterus and vagina. And in women that are kind of deficient in the lactobacillus, it is associated with maybe more difficulty getting pregnant, potentially pregnancy loss. The studies aren't incredibly clear, but there does seem to be an association. The issue is that right now we don't have the data to say that it's causative, that one thing causes the other, and then treating it then improves the outcomes. We definitely don't have that data, but sometimes we consider these tests in cases of recurrent implantation failure, when you've had several embryos that haven't been successful in implanting, or recurrent pregnancy loss. So, I think that sometimes when we've exhausted other options, we're always very thoughtful in considering what else it can be and what other techniques and tests are coming forward with some evolving data. But I would definitely say that we don't routinely do this testing. And in general, if we find any abnormalities on this microbiome testing, we tend to recommend just a suppository, like a probiotic. And so that sometimes your doctor might recommend that, without spending the money to do the testing. So I encourage you to talk more about those options with your doctor. Definitely not clear cut though, and not kind of standard of care across the board. Okay, so we're coming in the last 5 minutes, and clearly my room has become very dark. So I think I'll answer a couple more questions before signing off. Is an AMH of 1.46 okay at an age of 33? So ovarian reserve testing is something that's really important to talk about. Um, Women are born, I think I alluded to this, with all the eggs we'll ever have, whereas men are continuously making sperm, which isn't quite fair, but that's unfortunately the cards we were dealt. So in fact, the highest number of eggs you'll have is when you're in utero. So when you're in your mom's uterus at about 5 months gestation, you have 3 to 4 million eggs. And once you're born, that's already dropped to about 1 million. And you lose continuously up until the age of menopause, when you essentially, for all intended purposes, have no eggs left. So looking at AMH is a measure of ovarian reserve. So looking at how many eggs we have left. It doesn't speak to quality at all. That's mostly age related, but it does look to see how many eggs you have left. Now, it doesn't tell us your chance of getting pregnant on your own or through IVF, because as long as you're able to release an egg every month, there's a chance of getting pregnant on your own, even if your egg reserve is lower. What it does tell us is your reproductive window. So are you someone who's likely to go through menopause at the average age of 51, maybe a little sooner, maybe a little later? And it also tells us how you would respond to our ovarian stimulation during an IVF cycle, what types of doses of medications we need, and how many eggs we can expect. So I think that doing ovarian reserve testing is important, but it's also important to recognize that it doesn't predict the chance of you getting pregnant on your own at all. And it's not great for even predicting your chance of getting pregnant with IVF. An AMH of 1.46 at 33, I would say, is slightly on the lower side. It's definitely not a diminished ovarian reserve, but it is a bit on the lower side. Again, if you haven't started to try to get pregnant, definitely you still have a very reasonable chance of starting to get pregnant on your own, of getting pregnant on your own if you start attempts. But if this is something that you're thinking of delaying, if you're thinking of delaying childbearing for another, let's say 5 years, then I encourage you to speak to a doctor about your options, such as egg freezing, because that might give you an option if your ovarian reserve continues to go down, if you do delay childbearing for several years. So it's never a guarantee, but it does give women options down the line. So something to consider. I'm not worried by a single AMH value. But it's always good to speak to someone further about what that means and what your options are to kind of empower you to make the right decisions. Can an REI perform a salpingectomy? So, we're all trained as general OBGYNs. So we've done in the US, it's a 4-year residency for obstetrics and gynecology. I'm actually Canadian, so in Canada, it's 5 years. We get an extra year. And so in this residency, we're trained to do everything from delivering a baby to doing a hysterectomy. And we're fully board certified obstetricians and gynecologists. Now, as we take the time to specialize in reproductive endocrinology and fertility, sometimes we don't necessarily focus or continue to spend a lot of time in these minimally invasive surgical settings. So some people decide to not continue to practice this minimally invasive surgery. But I would say, there is definitely a good number of REIs that are very comfortable performing a salpingectomy. It's usually a very straightforward procedure. And if they're not, they can refer you to someone that is. So I think you'd be in great hands either way. So we'll get to this last question. What would be the pros and cons of doing an embryo adoption, specifically individuals whose own embryos are not working? At what point should a family be looking at surrogacy or other options? I think that's, again, a bit of a difficult question to answer without understanding your journey. Clearly, someone who's considering embryo adoption has been through kind of a roller coaster ride to kind of start coming to this conclusion that may be a viable option for them. I would say it'd be important to sit down with your doctor, look at your cycles, be able to determine, is this likely an egg issue? Is this likely a sperm issue? Can it be both? To see really how much embryo adoption would be expected to improve your outcomes. And there are other alternatives like donor egg or donor sperm, depending on what factors might have impacted your lack of success. So I don't think there's a right or wrong answer for for everyone. But what I would say is it's usually a big leap to consider these donor gametes, whether they be donor egg, donor sperm, or donor embryo. But for most individuals or couples who make that leap and get there, I can say that at the end of it, they're incredibly happy and feel like they're, they've kind of built their family, and it might not necessarily be the journey that they had expected from the start, but really it's all about that end result. So I encourage you to speak more about that option with your doctor. Okay, guys, there's literally no light left in the room. So I think that's all for me. It was so nice hearing all these clearly like very well educated questions. And it was really kind of a nice hour just chatting with you all. So have a great evening.